So by way of introduction, for those of you who don't know me, I'm Tess Harris. I'm the Chief Executive of the PKD charity. And I'm joined tonight by my colleague, Susan Muirhead, who's our support manager and is known to many of you. We have three expert guest speakers, Professor Geoff Woods, Professor of Human Genetics at Cambridge University, Dr Richard Sandford, Honorary Consultant Clinical Genetics at Adam Brooks, who I'm sure many of you will know very well indeed from his past and long time relationship with the charity. And finally, Professor Amanda Williams, clinical psychologist, works at the Pain Centre at UCL. So just a few background slides and some housekeeping about the PKD charity. For those of you who don't know us and are perhaps new to us tonight, we were founded nearly 21 years ago in 2000 by a PKD patient and a kidney doctor. And we're still today led by PKD patients and family members. And our vision is to improve the health and quality of life of everyone affected by PKD, and importantly, help find new treatments to slow progression and transform everyone's lives. We have three core aims. First is support and information. So this evening's webinar is an example of how we support people and provide information. And many of you will be familiar with our meetups and our face-to-face education days and our Facebook groups, and will have taken advantage of our helpline from time to time. We also do advocacy and raise awareness about PKD. And our third aim is around research. So we're able to fund research projects from money donated by members of the community over the years. But importantly also, we participate in research projects in what's called PPI, or Public Patient Involvement Initiatives. And tonight we have some examples of research in which we are a patient partner. We're incredibly grateful to the National Lottery Community Fund, who enable us to run these webinars through a grant that they've given us for 5 years. And as a medical disclaimer, remember that this event is for information only, and it's not a substitute for medical advice. You should always consult a medical specialist if you've got any concerns at all about care or treatment. So this agenda, in fact, Dr. Dick Sandford will speak first, and he'll be followed by Professor Geoff Woods and finally Professor Amanda Williams. So I'm going to stop sharing, and Dick, I think you're going to be sharing your slides.
I've had a lot of medical clinical experience in ADPKD over the many years, and I've been very, very fortunate to be able to interact with Tess and the PKD charity for a long time. And I think it comes as no great surprise to anybody here that pain is something that frequently crops up in some of our information days. There's been a pain-specific information day set up. So we all already know how important it is to individuals living with ADPKD and their family members. There's quite a significant medical literature that some people may have already tried to access, but just sort of pulling out some of the points that we see repeatedly mentioned in some of the medical literature that we're accessing. And it's often quoted that pain is experienced by about at least 50 to 60% of people with a diagnosis of ADPKD by the age of about 40 years. So this is a very, very significant burden of disease, or one aspect of the disease. And up to about a third of people, again, may use regular analgesics to manage this pain. And of course, we all know in ADPKD that there isn't one sort of pain. We often describe it, in a sense, break it down into what we would call acute or chronic. So acute and sudden, which is often can be diagnosed as a cyst infection or a cyst rupture or something along those lines. And that pain may last, for hours or days or perhaps weeks, or chronic pain, which is something that is experienced for a period of weeks, months, or longer than that. But we all, again, are well aware that this type of pain, whether acute or chronic, impairs well-being and overall quality of life for anybody who experiences it. So that's the sort of the very, very brief background to it. And so I don't think anybody will be too surprised by some of those facts and figures, which are very widely available. However, trying to quantify this in a little bit more detail and also to, in a sense, gauge its level of importance relies more than just having some headline figures. And in a fantastic project with the James Lind Alliance, the PKD charity has already prioritized what are, in a sense, the sort of the key question, the top 10 unanswered questions in PKD. And the James Lind Alliance is a superb non-profit making initiative established, I guess, nearly 20 years ago. And it brings patients, carers and clinicians together in these so-called priority setting partnerships to identify what the unanswered questions are or provide evidence of the uncertainties that they agree are most important. And of course, the aim of doing this is to make sure that health research funders and other organizations are aware of the key issues that matter most to the people who need to use the research or ultimately in their everyday lives. And what you can see very clearly here are those that you would expect. You know, you can look at the top priority, what treatments can maybe slow or prevent disease progression, who benefits from early treatment, but we get all the way round to number 6 and what treatments work best to reduce ADPKD. So all of this information is available on the PKD charity website, which I hope many of you have looked at already. So it's clearly one of the top priorities for people with ADPKD, how to manage pain. And of course, the PKD charity always gets there first, but the international PKD community have also been asking similar questions. And in this particular international group, SONG PKD, SONG stands for Standardized Outcomes in Nephrology, PKD for polycystic kidney disease, again has sought to establish what are the core outcomes based on the shared priorities of patients, family members, clinicians, research and policymakers. And again, you'll come as no surprise that the core outcomes include pain. So we've got an awful lot of information now that is prioritizing pain in polycystic kidney disease as a major area that clearly needs to be addressed through a range of different research and clinical initiatives. So I think we're, as I said, hopefully all aware that it is a key priority, and that's why we're here this evening. From the clinical side, I don't think there's any doubt that we have struggled over many years to know how to treat pain well and effectively in clinic. I put this up as simply as a sort of a fairly recent snapshot from one particular group based in the Netherlands, looking to see how they can support clinicians and ultimately patients in managing pain. And this is a sort of a stepwise schematic pain, which sort of starts off by asking the basic questions about pain. Is this pain directly related to polycystic kidney disease? And what are the initial treatment options? Are there non-pharmacological, non-drug-based treatment options? And they've spoken here about behavioral modification. That can be as simple as posture, for example, whether ice or heating pads might help, physiotherapy. And there was also a report not that many years ago identifying the use of a lumbar support, a corset, as being very effective for some individuals. And that then moves on to pharmacological interventions with this 3-step analgesic ladder, using paracetamol, stronger painkillers such as tramadol before moving on to opiates. And then there comes the minimally invasive therapies, which may be kidney or liver related, and that may be related to renal denervation, nerve blocks, assist decompression, for example. And then, of course, the more invasive therapies. So this was a very much an effort to try and support clinicians providing care for people with polycystic kidney disease to manage pain. But these particular clinical pathways are not always widely recognized. And so effective treatment and management of pain is not always available to everybody with this condition. And there almost certainly is some local, regional, and national and international variation in this area. I just flagged this particular slide up as well, because this actually dates back before that. And some of you on the call, I'm sure, will be very familiar with the use of Tolvatan and maybe taking this therapy yourself. That even nearly 10 years ago now, we recognized that there potentially were alternative therapies for pain in polycystic kidney disease. But let me point out that Tolvatan is not licensed for the treatment of pain, but it perhaps sheds some light on what the underlying mechanisms of pain are and how some people may benefit. And you can see, looking at the bottom slide here in this particular outcome measure, the risk of clinically significant kidney pain, you can see that compared to no treatment or placebo, those individuals taking the drug Tolvatan over 3 years of the clinical trial recorded less events of clinically significant pain. And that was really a very significant result. And you can see over here, sorry to dart about, that was one of the measures that was clinically significant. So Tolvatan improved pain as well as improved or slowed down the rate of disease progression. And clinically significant pain was defined as that necessitating medical leave, drug treatment, or some form of invasive intervention. And in the same study, a sub-analysis of that again showed that chronic pain in ADPKD with preserved renal function, so not necessarily advanced disease, may be severe and can lead to the use of drugs. We've already heard in about a third of cases, significant sleep disturbance, and again, significant impacts on physical activity and relationships with others. So I think we're well aware that pain is a significant issue in the management of polycystic kidney disease. And more recently published this year as well, a systematic review which was looking at the entire medical literature to learn a little bit more about how we measure outcome or how we measure pain outcomes in polycystic kidney disease. We've already heard of the significance of this, the justification for why we should be doing this sort of thing for the sort of studies that I've already mentioned. But despite being a critical outcome, the mechanism of pain is poorly understood. Pain is often under-recognized and poorly managed. And a lot of that is going to be due to the fact that we really don't understand how to measure or allow people to report pain. And in that systematic review, this looked at all the trials and observational clinical studies that reported pain in people with polycystic kidney disease. And there were some 118 of those studies reported. There were quite a number of measures of pain identified, but mostly those were for non-ADPKD populations, so they were used inappropriately. They related to many different anatomical sites, most commonly the back. There were different measurements of pain dimensions, intensity and frequency, different pain types and different impacts. But again, most were not validated in ADPKD. So there is a significant unmet clinical need for sort of a really good, strong, robust measure that captures patient-important dimensions of pain that is needed to both evaluate and manage this particular complication. So I hope that's done a little bit of setting the scene around pain in ADPKD. And now if I can ask Geoff to really sort of take us forward in the sort of the bulk of this particular meeting to describe his current research activity in this area. Geoff.
Thanks, Dick. So back in March of 2018, there was a meeting in London in Red Lion Square, which this is a picture of, and all the pre-Raphaelite painters lived in Red Lion Square, and Oliver Cromwell's bones are buried somewhere in Red Lion Square. So this was a meeting called the Focus on Pain, and it was put together by the British Pain Society and Versus Arthritis, because very much as Dick's been saying, in many conditions, it was realized that pain was the primary complaint or one of the main complaints, and this didn't seem to be addressed as far as patients were concerned. And there was also a feeling by pain researchers that there was not a lot of interest in funding pain research. And about this time, most of the drug companies withdrew from analgesia research. Eli Lilly remained, but everyone else pretty much left the scene, and no one was developing new analgesics. And so this was a very timely meeting. And the meeting invited funders like the MRC and the Wellcome Trust and Versus Arthritis to talk in the morning, and various types of researchers in the afternoon. And in some ways it was quite a depressing meeting, because the funders like the Wellcome Trust said, well, we already fund lots of research in pain, which everyone's a bit surprised at. And the MRC said, we'd like to fund more work in pain, but we've actually got lots of calls on our money. And in the afternoon, it became clear that the clinical researchers compared to the psychology researchers, compared to maybe the basic science researchers, were not talking to each other at all. And so this meeting occurred and we all attended, and then nothing seemed to happen. And then suddenly in spring 2020 actually, there was an announcement of the Advanced Pain Discovery Platform. So the first thing this did was get itself a logo made, which I can show you there after much angst between the participants. But this was quite an incredible move forward for pain research in the UK. You can see that the MRC put a large amount of money matched by Versus Arthritis. 2 more of the government-sponsored research councils put in money, and Eli Lilly put in a bit of money. And cumulatively, there was £24 million put forward for this pain platform. And there's been 3 calls for bids for the money. The first was for multidisciplinary consortia to generate data, to collect patient data, to be as a resource for people to do research on in the future. And 14 million was allocated to this task. Then there was a single data hub was bid for, which was got by a team in Dundee, which was awarded £2 million. And this data hub is going to collect all of the data and make sure it's available to the NHS and to researchers and between research teams. And currently at the moment, there are a number of project grants being bid for, up to £10 million worth of grants. And these project grants all have to be attached to one of the big consortia so that everyone is sharing as much data and as much resources as possible. So this is a vast injection of money for pain research. So we bid for a visceral pain grant, and our consortium is called ADVANTAGE, Advanced Discovery of Visceral Analgesics via Neuroimmune Targets and the Genetics of Extreme Human Phenotypes. This is Mike Lee, who's not with us today. He's got a grant call tomorrow morning, which he's desperately trying to get ready for. And Mike is our pain phenotyping expert, and he invented our mnemonic. And it did, but we took weeks and weeks coming up with increasingly desperate ideas for a mnemonic, because everyone seemed to have a mnemonic for their grant. So thank you to Mike for coming up with our ADVANTAGE title. So our aims. We wanted to build up a national visceral pain patient archive, which was a bunch of people who had visceral pain, for which there was extremely good clinical and other data collected and longitudinally collected. We also particularly wanted to discover if wearable technologies are going to be used in visceral pain. And I'll talk about wearable technologies later, but they're certainly widely used in the States, but almost not used in the UK. And we're the first big study to try and see if wearable technology is a better or an adjunct way of detecting pain in people. Most visceral pains can come in 2 flavors. One, a chronic pain, and the other is, as Dick was talking about, what's called flares. Unexpected, unpredictable, severe episodes of pain, and usually other features as well. And we particularly want to get our hands on some concept of what the visceral pain flares are. Maybe in ADPKD are a bit ahead of the field, but in many types of visceral pain, we have no idea what the flares are, nor how to treat them. As I'll talk about later, we wanted to define the specialist neurons that detect visceral pain, and pain-sensing neurons called nociceptors. We also wanted for our visceral pain patient archive to find what was driving some people to have more pain than other people. And we're particularly collecting those people with very severe pain and minimal or minor disease, and the opposite, those people with terrible visceral disease, but very little or no visceral pain. Maybe PKD would be an example here. Some people have large kidneys with no pain. At the other end of the spectrum, there are people with very small number of cysts with significant pain. So we want to find drivers of visceral pain, and we're going to look at autoantibodies. We're going to look at psychological drivers, and Amanda's leading that, and genetic causes. And obviously, we want to leave behind a collaborative network of people who've been involved in our grant to carry on working together in different groups. And there are 31 researchers in this consortium. It's the biggest consortium I've ever been involved with. We have £4.5 million to spread between ourselves. And you can see at the bottom here, there are 4 universities involved. Edinburgh, King's and UCL have joined us. Everyone who's going to be in the study is in the NHS. We're lucky to have a large number of charities who are part of our Patient and Charities Advisory Board. And I think Tess was the first one to join up, thank you. And there are 2 drug companies who have given us and another one of the consortium additional money. Eli Lilly and AstraZeneca have both put £500,000 of our funding into this grant. So we cover academia, patients, and I guess pharmacological industries. So this is how our grant is put together. We have a management board. Amanda, we have 2 data hubs where we collect patient data, one in the north in Edinburgh, run by Professor Andrew Horn, who I'll show you later, and in the south by Mike Lee in Cambridge. I'm supposed to be principal investigator, and we have our scientific lead is Ewan St. John Smith. And as all consortium is supposed to have, we have an international advisory board. Nachi Vigil works on bowel pain, Dave Bennett's neuropathic pain, Dr. Price, she works on endometriosis. No, he works on mice pain, and Stacey works on endometriosis pain. So Amanda is our PPI lead, but our first work package is headed by Tess, and this is a Patients and Charity Advisory Board. The next work packages are all to do with our patient collections. We're collecting endometriosis as a source of pain, inflammatory bowel disease, polycystic kidney disease, vaginal pain via those people who've had vaginal meshes inserted, had pain, and have to have the mesh removed. Pancreatitis is a cohort, and painful bladder syndrome is a cohort. And we're also looking at those people who have absolutely no pain when you expect they should have. We next then have our analysis cohort. So pain phenotyping is going to be done by Amanda and Mike Lee. The wearable sensors I'll talk about in a minute. Pain genetics is me in consort with another consortium run by Dave Bennett, who will be sharing all our genetic data. Autoantibodies will be done by Dave Anderson, and psychological drivers by Amanda, who actually is in a second consortium run by Edwin Keogh. And we wanted a specific work package to look for sex-specific effects, as it's becoming clearer and clearer. There are different pain mechanisms, not for everything, but for many things between males and females. And then feeding into the genetics is studies of the visceral nociceptors. So our Patient and Charities Advisory Board run by Tess. So we have 8 people on the board at the moment. We'd like to make that 10. And so we're going to recruit some more folk in the foreseeable future. And they're feeding in on a lot of the things we're planning to do. So for instance, the mix of people. Do we go for every ethnicity in the UK, or do we go for one type predominantly, or we just take anyone who comes? Do we make sure we've got a range of ages? Do we make sure we've got a range of what you might call social class, or certainly a mix of people who can readily access the NHS to those people who can't? We need a lot of advice about how to start using wearable sensors in an acceptable way for people. And we're going to get the wearable sensors, and I believe Tess is going to be the first person to try them out if she can get her hands on them. And then obviously genetic testing comes with lots of caveats about how much information and how many genes you want to look at. And do people want to know about other findings in genetics that we may come across? So all of this has got to be fed through the PCAB before we finalize our actual start of patient contact. So we have, as I said, 2 hubs, clinical hubs. This is PKD's focus. So Paul Phelan is up in our Edinburgh hub, which also includes an outlier in Newcastle upon Tyne. And there's 7 other clinicians and surgeons who are working with Paul on different types of visceral pain, and some scientists. And then Dick is down in our Cambridge hub, which is going to be run by Mike Lee. And he's again joined by a large number of other clinicians and scientists. And we aim to accumulate a large amount of information on 1,000 individuals. So we're going to survey far more than that, but from all the people we survey, we're going to get 150 in each group, concentrating on those extremes of maximum pain, minimum disease, and minimum pain, maximum disease. So we've got 2 cohorts of endometriosis, we've got a cohort of inflammatory bowel disease, polycystic kidney disease, vaginal pain, bladder pain, pancreatitis, and lack of expected pain. So all the clinical data will take a long time to collect, and when we're collecting this, wearables will come in. This is George Miliaris, who is an engineering professor in Cambridge, and his world-leading expertise is making the gel which sits between an electronic device and a person's skin, not causing irritation, not drying out, keeping the device stuck on your skin even if you have a shower, and being able to record information. And this is Thanasis Tanasis, another engineer, this time in Edinburgh, whose expertise is large amounts of data. And so what we're after is wearable devices which are already licensed for use, preferably cheap as chips, but they haven't turned out to be. We want to, for our 1,000 people, have 3 devices on a person for a month, continuously recording data, 1 an arm, 1 on a leg, and 1 over their place of maximum pain. And for that month, when they're wearing the sensors the whole time, we'll also ask them to complete a pain diary, and we're going to be able to record heart rate, respiratory rate, their position and their acceleration, so how quickly they're moving or not moving, muscle spasms, particularly by the sensor over the abdomen, and possibly in later iterations, temperature and sweating, and maybe even cortisol levels. So this is a vast amount of data, and it's designed to be almost an overkill because we do not know the best way to record pain using a wearable electronic sensor. There may not be a best way, but by having all these different measures going on linked to people's pain diaries, and also them telling us where they think their pain is the worst, hopefully we'll find which of these recordable devices in the future will be the best for looking at how much pain a person is experiencing. And then the huge advantage of that is it means in the future, we might have a much better way of seeing how well our therapies are working for people. The next big area is the pain sensing neurons. And this is a large focus. The whole focus of the grant is pain. So we're not concentrating on people's disease that gives them the pain. We're concentrating on the pain. So if you take the gut, we don't care if the gut's been squeezed or it's acidic or inflammatory cells are inflaming the gut. All the messages of pain will flow through a pain sensing neuron, a visceral nociceptor. And so it doesn't matter which of these are the input, this is the final common pathway sending pain impulses to the brain and being perceived. So we want to define what these nociceptors are. We already know from some work done by others and some work done from one person in our group that the pain sensing neurons for the viscera are different to the other pain sensing neurons in your body. For instance, if you cut your hand, you break a bone, there's a set of somatic nociceptors which detect that signal. We know they're not the same as the visceral nociceptors. And so we want to define the genetic makeup that defines all visceral nociceptors and then defines the visceral nociceptors serving the uterus, the bladder, vagina, kidney. You know, it's not going to be the whole kidney. We're going to be looking at the kidney capsule and the ligament that supports the kidney and the other parts here, apart from bowel, which has already been done, which is why we know that visceral nociceptors are different to somatic nociceptors. This is not going to be a perfect study because it's going to be done in mice, because it's only really possible to do this in mice. We're going to be looking at the cell bodies of the neurons to see what genes are expressed there, and not the nerve termini, which will be sensing pain or transmitting pain. To give you some idea of how strange a cell a neuron is, if this was to scale and that was a 10p piece in size, the cell body, this axon of the neuron would be 2 kilometers in length. So they're an amazing cell. And we're not looking at the disease state for any of the visceral pains. So we're getting data from what you might call resting visceral nociceptors, so we can define them and not look at what they do when they're actually stimulated. This is Ewan Singer-Smith, who is going to be doing most of this work. And this is Francesca Denk, who is a data analyst and also a pain researcher. And she's going to be analyzing all the genetic outputs from Ewan and trying to make the results he has fit into groupings and define which are the, which are the pain sensing neuron signatures. Now what Ewan does is injects a dye. Now this is a mouse uterus, unbelievably. If you put a dye into this, the dye is called fast blue. I'm sorry about that. And it is taken up by the nerve termini and eventually moves along the termini to the nerve cell body. And this is a picture of some sensory neurons which he studied. If you wait 2 or 3 weeks after your injection, you will find that the dye is in some of these neurons. And then Ewan extracts all the genes from that particular neuron and then Fran does the analysis. And so this is a very rigorous technique because it allows you not to look at these neurons which aren't producing the visceral pain, just the neuron you know is coming from the organ you've injected. This data will be obviously very valuable. This should be the first time in the world it's been generated, and we're going to share and contrast it with one of the other collaborations, PainStorm, which is looking at neuropathic pain. And so we're obviously going to look what is the unique features of our visceral nociceptors compared to the neuropathic pain receptors, and also see if there's new pain genes which are shared between the two. Eli Lilly have bought and generated a large amount of sensory neuron data, and they're going to share that with us for no cost. And this type of data we're generating, hopefully, will give us a relatively small number of genes which are essential for visceral pain generation, and that will then guide us for the studies I'm going to be talking about now, but ultimately, hopefully, lead us to pain mechanisms so we can generate novel visceral specific analgesics, of which there are none at the moment. And as you're all well aware, not all of the analgesics work in visceral pain, that work for other things. So what drives visceral pain? And we have 3 approaches here. I'm sure there are many drivers of visceral pain we're not going to study, but we chose to study these 3. This is David Anderson from King's, and he's been looking at autoantibodies as a cause of pain. And he's particularly had success studying fibromyalgia and complex regional pain syndrome. And he's found that plasma from patients with these conditions will give pain phenotypes in mice. And the pain phenotype he gets from fibromyalgia patients, their serum injected into mice, is different to that from complex regional pain syndrome. And as we know, fibromyalgia is a comorbidity, and in quite a significant number of visceral pain cases, we're wondering if autoantibodies are both driving fibromyalgia type pains and some of our visceral pains, or whether there's actually specific autoantibody drivers of visceral pain. Also, David's work will fit in nicely with our wearables to see if the pain behaviors he's seeing in mice are echoed in humans and vice versa, because then you can potentially try your drug therapies in mice with visceral pain and be able to record if it improves their pain behaviors or not. Psychological drivers, and I'm not going to say anything else, I'm going to leave that to Amanda, but this, we were absolutely delighted when Amanda chose to join our study. And then genetic drivers, we're going to look at a range of types of genetic changes. And we have, we're not going to got Gregor Mendel in our consortium. I'm going to be looking at Mendelian disease. Someone called Patrick Chinnery, who's a professor of neurology, is going to be looking at mitochondrial DNA, which we know can drive pain conditions, and we know can actually, some mitochondrial diseases can cause painlessness. And then Serena Nix is a cancer geneticist who has used the genomic signature of cancers to differentiate different types of cancers and now depict which mechanisms are causing particular types of cancers, which then predicts which treatments will work for that particular type of cancer. So we've got these three experts putting in results, and then we're cross-correlating our results with Ewan and Fran's work from the Painstorm and Dave Bennett from Eli and AstraZeneca. And obviously what we're after is, do we have any changes in visceral genes we know are in visceral nociceptors, which are actually making some people feel more pain and some people feel less pain, visceral pain, than others. And hence, can we design new analgesics to those new pathways? PKD. So just focusing on PKD in our study, we have decided just to do autosomal dominant and not recessive and not other types of polycystic kidney disease. Dick's finalizing whether he wants everyone to be in radar who we recruit. And we're also deciding whether we want to know if they have a PKD1 or PKD2 mutation or not. This is a very difficult, the PKD genes are very difficult to sequence, and Dick has mastered this in Cambridge, and the genetic approach we're using is probably not as good as that which he has operating in Cambridge, and certainly doesn't have the huge experience he has of knowing which changes in these genes matter and which don't. And they are genes which are known as polymorphic, which means they have a huge number of changes, which are far more than you would expect by chance, but they can't all matter. Who is going to join our study? Well, it's all going to be done initially by volunteers. People will volunteer via an online portal, which Mike Lee is finalizing at present. And then from the volunteers, which will hopefully be nationwide, we'll be picking people to approach to ask further details after a preliminary questionnaire, again into our two different pain divisions. The initial approach will be an online app, and when you've done that, you can then give your consent to go further and tell us where you live and give us your NHS number. And at that stage, we would then start to bury away into the NHS data to get information. We'll send you forms for consent and a brief pain questionnaire and possibly other questionnaires, but Amanda's still considering this, and we'll want a blood sample to get both serum for antibodies and DNA for genetic testing. We have some very medically based inclusion and exclusion criteria, which are pretty much fixed now, which will be passing via the clinicians recruiting patients for us. And then back to what we'll be then doing. Already, as Dick's mentioned, there are at least two types of pain we are particularly interested in. Oops. And we'll be looking at both of these separately. We'll be using a number of measures to assess pain, the pain diaries and more that Amanda and Mike are doing, the wearable data, and also an app which will either be on your phone or your tablet to show where your pain is. And that's proving quite difficult to get a 3D rather than a 2D pain app working. And we'll be comparing our pain against various disease measures and trying to find correlations. So obviously kidney size, renal function, as Dick's mentioned. We'll be looking at all medical comorbidities from the NHS data. And also particularly we'll be looking at other pain comorbidities. How often do people have specific other types of pain? And is that by chance, or actually is that some type of syndrome where you do get multiple pains occurring together? And then in the Cambridge hub, Mike will be calling people in to do pain phenotyping. He'll be trying to work out how much pain, people's pain threshold they suffer, how much pain they can bear without actually causing them pain. And I'll just share one thing he'll be doing with you for your delectation. This is the cold pressor test, which is a device for looking at pain tolerance. You put your hand into that water bath, which contains water at about 3 or 4 degrees. And you are asked to keep it there for 2 minutes if you can. And if you cast your minds back to when you used to throw snowballs at each other, you'll remember that your hands can get cold. And then after a certain time, if your hands have been wet and cold long enough, they suddenly start to burn. And that's the pain that after about 30 seconds you get in the cold pressor test. And that pain doesn't get worse, but it persists. And we can measure quite carefully how much pain people can put up with. And that can guide us to how much pain tolerance people have. And Mike has a number of other, mostly much easier to tolerate tests than this to work out how much pain people can take at a various time or not, to see if that correlates with how much pain they're suffering in their visceral pain condition. There is another pain in PKD study going on at the moment, and Tess organised a meeting last night at about this time between the EASE PKD study and our study to see if we could work together. And the answer is we are going to, and this is now going to be led by Fiona Corrett in Cambridge, but actually Mike Lee and Richard Sandford are both in EASE PKD and in ADVANTAGE. So that's going to make that collaboration, I guess, much more fruitful. And we're not going to try and share every patient, but we are hoping that some patients will be in both studies, and then we can compare the approaches to pain sensitivity, which is going to be the most useful. I'll just end with a nice, happy picture of the summer, which we can all have again in about 4 months' time. Thank you very much, and over to you, Tess.
Thank you, Geoff. Before we start looking at the questions, I will now ask Professor Amanda Williams, to join us and share her slides. And at the end, we're hoping to make this a bit of an interactive session. So if we do run over a little bit, I hope speakers won't mind, because we want to ensure we get some feedback from you. Amanda will explain. Over to you, Amanda.
Thanks, Tess. The more I've got involved in this, the more I've realized that psychology is based very much in pain on back pain and musculoskeletal pain. And although there are studies of visceral pain, they're quite diverse, a lot of pelvic pain of various origins. And so rather like thinking about nociceptors, we're going to have to go back to the beginning, but I'll just take you through where I think psychology fits. So psychology is always part of having a medical problem. If we're lucky, it's a small part of it, but of course we're anxious when we don't understand our symptoms. We can be distressed by them. They can stop us doing the things that matter most to us, stop us going on holiday, seeing our friends, or affect the way in which we relate to other people. And the tendency in treatment is to go for the disease and hope that the pain will resolve with disease. But as Geoff made clear, pain and disease barely co-vary. So you can have a lot of pain with very little evidence of disease, which is very frustrating for people who present and are told they've got nothing particularly wrong and to go away. And you can have a lot of disease with not very much pain. So one of the things psychology works to get towards is trying to develop a more integrated model. And that's one way in which the ADVANTAGE project is very nice by, having an integrated approach to this. So pain is processed in the brain. So of course it's psychological, and it's influenced not just by one's balance of neurotransmitters and connectivity and so on in the brain, but by mood on a momentary basis and on a longer term basis, by context, social context, clinical context, and so on, and by beliefs and one's liability to feel things are threatening and anxiety making related to health, or the extent to which one doesn't pay attention to them. So all these things actually affect the experience of pain, not just the reaction to pain, but the experience of pain itself. And we knew that a long time ago. This is, over 50 years ago. People were talking about this, but I think we still don't really clinically treat pain in a way that recognizes this, that attention, emotion, memories, and so on, all have control over the sensory input of pain. And The psychology of pain started off in a rather psychiatric way, and it was really quite judgmental about people, which fitted with moral ideas of being brave and not complaining and so on. Psychology has moved more and more towards trying to see it in a normal way. We all have pain. We all react in different ways at different times and in different settings. And it doesn't help to see it in terms of psychopathologies. And pain is always emotional. It's always got meaning. And it's potentially a threat to, you know, what's happening in our day-to-day lives. And that emotional meaning affects how pain is modulated, as I said, in the brain. And so treatment needs to affect not just how people adjust to pain, but also the meaning of pain, how people understand it. And therefore, whether worsening pain is likely to make them feel very frightened and unable to cope with it and liable to go to accident and emergency, where they may or may not get the help they hope for, or whether people manage it themselves and carry on with what they want to do. It's not just about intensity of pain, it's about the extent to which it feels threatening. And the definition makes this clear. It's a sensory and emotional experience. It's never just sensory, it's never without emotion. And there doesn't have to be any tissue damage. This says associated with or resembling that associated with actual or potential tissue damage. So there doesn't have to be anything visible or findable on investigation to have pain. And I think it's helpful to think of pain as an urge to act. And the way it's processed in the brain isn't just saying, what's this? Is it touch? Is it temperature? Oh no, it's pain. It's actually saying, what should I do about it? And the motor areas are active very early. And because it's a subjective experience, of course, only the person with pain can say how bad it is. And it can't be confirmed or disconfirmed by physical findings. The physical findings may or may not emerge, but they don't tell one that someone does or doesn't have pain. Of course, that's very difficult for medicine, which relies, you know, very understandably and with a lot of success on actual physical findings. There's not been a lot of work on what pain means in PKD, but of course there are fears of what's wrong now, of progression of disease. You know, if people are managing without the fear of worsening and needing transplant, needing dialysis, there can be worry about not being believed, about how bad it is, or that there's pain at all. And people can have quite bad pain even early in the disease when there are very few cysts visible. There's anxiety about whether the pain relief offered will be enough. And day to day, it affects people's activities, their work, their social life, the energy they have left over after all the day-to-day self-care to do other things that matter more, and people's plans for the future. So rather higher than the estimate that Richard Sandford quoted, there can be really high rates of pain even when the disease is said to be mild, and often then the pain doesn't really get acknowledged or treated adequately. And this comes from a study of people diagnosed with PKD, and one said the word fatal was used a lot during the discussion of the diagnosis. That's pretty terrifying, and that will affect how somebody feels and certainly how they might interpret worsening of pain. And then people talking about, you know, worries about disease progression. And quite understandably, pain therefore accounts for variance in depression. So the more pain people have, the more depressed they tend to be. And of course, that adds to their problems. There are often anxieties associated with pain. As I said, progression, the possibility of unpleasant treatments, hospital stays, difficult investigations, dialysis is really dominating thing to have. It's pretty hard to have a life as well as it. Limitations in future. People wonder whether to pack in all they can do now because they feel they might not have many years of an active life, or whether to try to spare their energy now and hope they can reserve it for the future. Very difficult decisions people are making day to day and year to year. As I said, worry about pain relief. And what helps anxiety is firstly understanding risks and feeling one has good access to information. And of course, organizations like PKD can be very helpful with that. Having access to experts, and the NHS is rather taken to, even in chronic disease, to discharging people back to their GPs, which often makes people feel less safe and uncertain of whether worsening will be picked up. So it can actually worsen the experience of pain. People want to know what to do, what next year may hold, what to do when they feel worse. And there are a lot of papers about doctors talking about giving reassurance, but of course it's only reassuring if it reassures. So just thinking one gives reassurance doesn't mean that one has changed anything for the patient. And so we can understand these things about how to help anxiety, but clinicians often don't have the time or the resources, or the system doesn't allow them to provide what might help anxiety. Then with depressed feelings, people worry about loss of their present capacity, losses in the future, plans for career, plans for family, plans for retirement, whatever it might be. So there's a lot of actual loss and anticipated loss. And of course, the losses are real, but they can be mitigated. It helps to have good information to do so. It also helps to understand how depression affects memory, because the more depressed the brain is, as it were, the more it throws back in great detail things one doesn't like about oneself, things one's not, bad memories in full technicolor. And it makes it quite hard to remember the better things in life and about oneself. And even exercise can play a part, of course, often a problem for people with chronic pain in tackling depression. So the aims of any pain treatment, whether it's pharmacological or surgical or psychological, should be to try and help control of pain. But of course, if you just go for control of pain, it doesn't help the worry about pain in the future and the concerns about long-term analgesics. Helping people to understand the problem, to reduce the impact of pain on everyday life. But if the focus is just on how people cope, they can feel rather left alone with the pain and the anxiety about it, and reducing distress associated with pain on the wider network as well. So that's what psychologists do to try to help with chronic pain. And they help to some extent. We're not good at matching patients to treatment. They're as good, or one could say as disappointing as other treatments for pain. We certainly don't have great answers. But they do help people feel more in control of their lives, more able to plan, less distressed by the present and possible future limitations, and to educate those around them to try to support them better, including medical team, GP, and so on. So it is helpful, but small to moderate differences. We'd like them to be much bigger, and it helps people get back to doing things. That comes from systematic review data, which is fairly strong. But actual clinical treatment can be better than the trials, because trials tend to be very protocolized and rigid in the way they're run in order to control all the variance, but if treatment is personalized by experienced clinicians, it can be more powerful than what's in the literature. There are very few trials, even on pelvic pain. Most are on either mixed chronic pain or musculoskeletal pain, which is the majority in mixed chronic pain, and none I found on kidney pain. And the European Association for Urology guidelines suggest that one should try psychological interventions that work elsewhere and to try them alongside medical or surgical treatment. At the moment, people usually only get offered psychological interventions when everything else has failed. And they could do with a lot of the psychological elements quite a lot earlier. So this is just a rough map of the kind of treatments available to people with chronic pain in general. And you can see that things like multidisciplinary rehab, mindfulness, CBT, all psychological treatments are as good or as not so great as opioids and antidepressants. So psychological treatments are in the same league as those, but as I said, disappointing in their overall effects. So what I hope to be doing in ADVANTAGE is really asking, through a lot of quite intensive interviews with people with visceral pain, how they understand their pain, what makes it worse and better, how they understand flares, and how it affects everyday life. And really trying to get a sense of whether the psychological models we have, which, as I say, have generated effective treatment, although it could be better, whether those models apply well enough, how they could be better for people with visceral pain, and therefore how we can offer more in treatment. So I shall be looking for volunteers to talk to me for about an hour about pain and your own experience. And then, I mean, that'll be well over 100 interviews, and then trying to put that all together and create a solid database that talks about visceral pain specifically. And then one of the first things we're doing is trying to survey people about where they show pain. And this is what Tess said we would come back to. And we're grappling with how best you can show internal pain on what's effectively a 2D representation, whether it's on paper or on screen. So I'll come back to that when you'd like us to, Tess. Thanks.
Thank you very much, Amanda. So we're just slightly over the hour, but if you've got, if I could ask panelists, speakers to just hang on for a few more minutes. We did have some questions, and in terms of your interviews and the survey, as I understand it, for ADVANTAGE, the intention is to send out widely a survey questionnaire, which would be asking people questions about their pain, severity, frequency, and so on. And then in addition, asking them to describe, to point to where the pain is using these body maps, and to also describe their pain. Is that correct? Is that my correct interpretation? Oops, you are on mute.
Sorry. Oh, rookie error. We'd like to survey well over 2,000 people at that sort of level. I can just quickly show some of the body maps if you'd like me to.
Thank you. That might be helpful. Just give people an idea of what a body map is.
I'll just share my screen again. So
and this could be something that we send out to attendees, perhaps, of this webinar, to ask for a little bit of feedback. If you just
well, exactly. Them. I mean, this shows some of the choices, and you see how hard it is on any of them, even the ones that are divided into lots of sections, to show visceral pain and also to show perineal pain, unless you give that sort of rather technicolor view of the perineum. It's really, people find it hard to show pain that's deep inside on these, and inevitably they need annotating, and even the ones that a better representation of a 3D body don't really allow you to show pain inside as distinct from on the surface. And people might want to show both.
Okay, thank you. So we'll probably be circulating some of these maps to people who've attended just to get your responses. So look out for an email from us about that. We do have a couple of questions that either Dick or Geoff. Well, one of the questions was about signing up for Advantage. So the stages are that the survey will go out as widely as possible, and we'll be asking as many people as possible with PKD to complete it. At the end of the survey, there will be what's called a consent form, and you will then express an interest, if you're interested, in taking part in the Advantage study itself. Now, there are geographical restrictions in that patients who come forward will be asked if they can attend either Edinburgh or Cambridge to have the detailed studies done that was described earlier. Geoff, I don't know if you wanted to add anything more on that.
No, we've wondered about having other centres, but it's difficult. And I think actually the pain phenotyping that might want to do will only, I think, be done at Cambridge. We're hoping to train someone for Edinburgh, but that's not clear yet. And we're sorry, it's not more inclusive.
And somebody did ask about the criteria. So those will be explained in the form to determine whether or not you're eligible to come forward for the big study. But your input to the survey will be incredibly useful, even if you can't take part in the full study. Because as Dick said earlier, we're looking for 150 people with PKD in total, and in particular focusing on those extremes. So we know a lot of people who have said to us they're early on in PKD and they're suffering chronic pain. And they go to doctors and they're disbelieved, you know, kiddies don't feel pain and so on. We're really interested in Advantage looking at investigating why that's the case. And also at the other end, we know many people, I would count myself into that group, who've gone as far as possible nearly in the disease stage, have big kidneys, would be expected to have chronic pain, and yet have never experienced it. So those are really interesting extremes that the Advantage team will be studying as well. But everybody's input will be incredibly helpful to build a better understanding and knowledge base about PKD pain. Somebody had asked a question about, I think we used to call it referred pain. Dick, would you like to comment on that quickly? Whether chronic pain from the kidneys might be related to other organs being restricted in the abdomen. I think particularly where you've got big cystic liver, people often can't differentiate between kidney and liver pain.
I don't know of any particular work per se, but I think we all certainly suspect that that may be the case. You know, even something as similar to sort of compressing the stomach and causing, you know, difficulty with digestion and reflux, for example, is often quite a potent cause of abdominal and chest pain in that sort of situation. So I think it's very likely that is the case. I think it would be something that would be very difficult to study.
And possibly just one further question. So Vicky had asked about, actually a question for Amanda here on the maps, saying that visceral pain can cover a large area, it's not pinpoint. So how would you propose to demonstrate the surface area really of, well, surface area is probably not the right word, but the extent and density maybe of the pain?
Well, people will be able to sort of shade in as much of the outline as they wish to show where their pain is. It won't be, I mean, the least popular seem to be the segmented maps where you press on them and then it fills in that whole segment, because particularly for internal pains, they just don't map the segments at all.
Thank you. We've had somebody thanking everybody speaking tonight for your time and your expertise. And given there aren't any other burning questions or painful questions at this point, I would like to say thank you once again to Geoff, to Dick and Amanda for giving up your time this evening and explaining about ADVANTAGE and the research studies that we've taken place. And look out for emails from me asking you for some feedback on the body maps. And later on, we'll be hoping to distribute the survey widely and potentially through Patient View as well, so that people who are logging onto Patient View will also be invited to join the survey. Thank you everybody for attending. I hope you have an enjoyable rest of the evening. And let me reassure you that if any of you are concerned or were a little bit upset about what you heard tonight, don't hesitate to get in touch with us. You can always text, direct messages through Facebook, or ring the helpline in the morning. And don't stress alone if you're feeling pain.
Thanks, Tess.
Thank you, Amanda.
Yeah, thank you very much indeed. Good night.
Good night.
All.